Guys, after subscribing to this channel, please make sure that you also press the bell icon so that no notification, no new video of mine, any educational video, is missed by anybody.
All right. So good evening, everybody, and welcome to this class. We'll be discussing the October 23 paper number 3 tonight. And I hope everybody is there in my chat room as well, because I usually want to keep it a very interactive session so that you people don't sleep off in my class, don't get bored, and are there enthusiastically involved as most of my students are. And since this class is on its regular time, I hope, and I suppose all my students who don't see the time again and again in my off-repeated and change time intervals are there by default. And here we begin this class on a very, very positive note. Let's discuss the first question. So this says about the etiology of uterovaginal prolapse. Okay, so whenever I talk about etiology of uterovaginal prolapse, the very, very old question, number one. So this question's answer you know since I think when you were in the MBBS undergraduate level. So this is what they've asked you. So what question is not about you knowing this or not. It's also how you present it. So if I'm the examiner and somebody writes an answer like this, I'll give full marks, because there are headings and then subheadings and subheadings, and nobody, really reads what's inside the heading. But headings have to be very crisp and they have to be there. So the idea of these answers are to make you understand for a particular given question, how are you supposed to approach the answer. If this is the way you approach with headings, subheadings, and subheadings, well, I am not going to, it'll make my work easier, first of all, because in one go, I understand that you know the points. Number two, the way you've presented it, it's I can read and understand it in a much simpler way. And I know in one shot that you know the answer, right? So now let's begin with, and one more thing, guys, which I always say, please, everybody who's there in my Telegram channel right now can just go and click on the pinned message on the main channel. Obviously, once you click the main channel pinned message, you enter my chat box or the chat room, as I call it. So please do that. Everybody who's there and who's not yet entered the chat room, that's the way to go about it. There's a pinned message on the main channel, on my Telegram channel. Just click it, and there is a link to enter the chat room. Now, so if etiology of uterovaginal prolapse is asked, you know what it is, right? But this is how you present it. So one is childbirth. So the number of vaginal births are going to decide how much lax the pelvic floor becomes, and because of that you have uterovaginal prolapse. Otherwise, also aging is one factor. The tissues, they get more, the more and more lax. Menopause, that also causes, it weakens, the supports of the pelvic floor, pelvic muscles, and the connective tissue shows changes, and because of that, it kind of becomes more and more lax. Chronic straining because of constipation, because of lifting weight, constant and continuous cough. These are all reasons for uterovaginal prolapse. Obesity is another very important factor, because this chronic weight, okay, and that gravity, kind of pushes down the those organs which are associated with a cavity. So it can do that. Genetic factors. There could be some patients who are genetically predisposed, right? Chronic coughing, as I told you already. Connective tissue orders. This you can also say this is chronic. This genetic factors: Ehlers-Danlos syndrome, Marfan syndrome, and these are the ones in which already the connective tissue is so weak that they can have prolapse, even nulliparous prolapse. Any previous pelvic surgery, maybe the ones which weaken the supporting structures. That could be chronic heavy weight lifting that we've already seen, like especially the females who are working on the roadside, especially the labor class workers. They are the ones who have a habit of lifting very heavy loads, and though you don't associate it with that base, but professionally they can have this problem. And then there are certain contributing factors like multiple pregnancies, or having had large babies, or babies at frequent intervals. Then smoking is a contributing factor. Any respiratory condition which leads to chronic cough situation every now and then will be a contributing factor. Any neurological disorders like multiple sclerosis, spinal cord injury, that has also been attributed to causing prolapse. So this is just how much mark question was this? Looks like a 5-mark question. It's not written over here, but then this is the beautiful answer which I've tried to prepare by giving you etiology and contributing factors. Now, this is actually one of those flowcharts which I had used in my class before. Okay, and this flowchart tells you actually the entire management of prolapse. This has not been segregated into any particular case, and I find this one of my favorite charts which I've prepared. I'm pretty proud of this chart, I would say, because in one go you understand what is the management of prolapse. And here I've included everything, even the conservative measures, the surgical measurement measures, the UV prolapse per se, the nulliparous prolapse per se, the vault prolapse, everything I've included. But your question to come was something like this: a 28-year-old para 2 lady. That means she's in a reproductive group. She's probably had a family complete, and now she's complaining of a mass descending. And remember that the question is about mass descending per vaginum. It's never said that it was prolapse. Okay, so obviously, whenever I talk about management of any case, I start from history taking. This is also what examiner wants to see. So you start from history taking. How do you know what this mass is? It could be, well, a big fibroid, cervical fibroid. It could be a Bartholin cyst. It can definitely be a prolapse. It could be so many other differential which I'll be discussing. So you have to take a proper history. When does it descend? What kind of mass is it? Does it bleed as well? Is there discharge? Is it foul smelling? Does it come out with straining, or it's always there? Something like that. Then obviously you'll have to do physical examination. Then you have to make a DD. Okay, it's one of which is uterine prolapse, of course. Then you have to talk about vaginal. It could just be a vault prolapse. Maybe she's already had a hysterectomy done. Then what could it be? And could be a cervical tumor or a Bartholin cyst or abscess. It could be fibroids. Okay, and endometriosis. This is very far-fetched. Okay, you can just miss it. Investigations. How will you see? Once you talk about history, then you talk about physical examination, then you talk about DD, and then you talk about the investigations. Then you finally talk about the treatment. That means the management. And I wanted to ask for the treatment. I would have asked the treatment. This is management. How you manage the case. That means you start from history, physical examination, make a DD. You remember, many of you were there when I was when I was taking your case discussions. And right from the very beginning, when you would tell me the history of the patient, the presenting complaints, and why you were asking these questions, I would ask you, what is the DD in your mind? So people were very zapped, because this is what happens. When a patient comes to you and gives you the complaint, which is from where you start, formulating a DD in your mind, and your questions of, history, your history asking, your physical examination, the questions are directed in that place, right? So now, investigations where you have ultrasound, you have cytology, biopsy, you have MRI, you have CT scan. Why you want to just delineate it's not one of these DDs, right? That's the only thing. Once you're sure it's prolapse, obviously you don't have, you can forego all these DDs, these investigations as well. And now you come to the management, because now you've planned that probably it is a prolapse. How will you go ahead with the management? So you have conservative measurements that will always be there. Okay, for even nulliparous prolapse, you have conservative, measures. So always remember the conservative measurements. But medical management I've written over here because it's a mass per vaginum. So if you have any underlying disorder like maybe chronic inflammation, infection, then probably maybe antibiotics and anti-inflammatory medicines. Otherwise, there is no need. Surgical management has to definitely come when I'm talking about if it's a prolapse. Obviously, there's no medical management. So here you have some specific surgical approaches. Definitely one is the vaginal procedures, including vaginal hysterectomy or anterior posterior colporrhaphy, which everybody wants to hear from you, right? Then you have certain uterine preserving procedures. See, she is a 28-year-old female. We've not been told that the family is complete. We've not been specified whether she wants to keep the uterus or not. But at 28 years, I expect that she would want the uterus. So here you have uterine preserving procedures as well, which you would want to say sacrohysteropexy is there, uterine suspensions are there, all the sling operations you can mention over here. And then combined procedures. So you can have anterior posterior repair with hysterectomy together, and you can have mesh augmentation techniques. And of course, the same thing goes with laparoscopic, the same thing goes with robotic assisted approaches as well, right? If you've got any doubt, guys, you are more than welcome to discuss the doubts over here. You can just message me, and I will be able to answer you during the class as well, or immediately after the class.